Hello and welcome to Common Part B Independent Diagnostic Testing Facility Rejections and Denials. I am Mary Moko. I'm a member of the WPS Provider Outreach and Education team at WPS, and I will be your presenter today. I'm joined by my friend and teammate, Bailey Lawson. Bailey will be assisting with some behind-the-scenes help. You may hear her coming in and out of the presentation if I ask her for any help or call out to her. This webinar is for those people who are wishing to learn a little bit more about the most common reasons for rejections and denials of Part B claims submitted to WPS by Independent Diagnostic Testing Facilities, or IDTFs. CMS does require that the Medicare Administrative Contractors, or MACs, like WPS, provide this type of education in order to prevent future claim rejections and denials. And just as the information that we added in our advertisement, the information that I'm presenting today is based on actual claims data for rejections and denials. This presentation today is not intended to delve into policy and payment for IDTF services. We're going to focus on the data for the most common rejections and denials. But first, I do have a little bit of housekeeping information to go over. The presentation is available to download from our live events webpage. That page address is in the chat. You may take time to download the presentation materials now if you've not already done so and you wish to do so. We will be recording this session, and barring any technical issues, we will post it on our Encore Presentations webpage, where it will remain for about 60 to 90 days. The recording will also be published on our YouTube channel, where it will remain as long as the information remains current or until we otherwise determine we need to remove it. Now, if you have questions, please place them into the chat. I will be answering questions as time permits, but if I don't get to your question, I will email the response following today's webinar. I will email directly to the learner that posed the question, or I will compile a list of questions and answers and share them with all participants in an email. I am unable, though, to provide answers to claim-specific questions. For those, you need to contact customer service so that they can access claim history and details in the Medicare claims processing system. People in provider outreach and education at WPS are unable to do that because our tasks or responsibilities based on CMS directives is widespread education. Here is a disclaimer that we include in all our live events, and it's to let you know that this presentation today is for educational purposes only. I did make every effort to verify that the information is current and accurate, but it is subject to change. It is on the CMS website where you're going to find those Medicare rules that determine final coverage, and it is those that will always prevail. Finally, CMS prohibits recording of this webinar for any profit-making purposes. We ask that you do not record this presentation. We are doing so and will create an encore of the presentation, a YouTube video, and you may use that for future reference. Based on the American Medical Association's copyright notice for CPT codes, descriptions, and other data, I've included this CPT copyright notice in the presentation materials. You'll see it here on this slide. Your continued participation in this presentation infers that you agree to the terms of this copyright notice. Here is the agenda for today's webinar. It's exactly what the advertisement stated, so it will look very familiar. Today, my goal is to share with you the reasons for the most common rejections and denials for Part B claim submissions to WPS by Independent Diagnostic Testing Facilities, or Specialty 47 providers. This is, as I mentioned, not a deep dive into policy and coverage, but it's really a look at those most common reasons for Specialty 47 rejections and denials, and it is based on actual claims data. I'm going to define rejections and denials, and we'll talk about the difference between them. I will reveal those reasons for rejections and denials based on that data that I pulled and analyzed. I'll discuss ways to fix or avoid these, and I'll provide you with many resources. There is a lot of information to share with you in 60 minutes. I will be moving quickly through the slide deck, and I may ask you to review some of the information following the live presentation. If you have questions, I'll remind you later how you can send them. In order for me to discuss rejections and denials, I really need to provide a bit of information about the claim process. Based on a law that requires that most providers submit claims electronically to Medicare. When doing so, there are reports that generate that will let the provider know that the claim was received, and those reports will also offer more specific information about data requirements. Now, one of these reports is the 276-277 report. The Medicare 276-277 companion guide, you can see I've embedded a link to it in your presentation materials, was prepared by our electronic data interchange or EDI staff. And this really helps claim submitters understand the claim requirements and know when they need to correct or resubmit the claim based on what we call pre-pass edits. Claims that move past those pre-pass edit, those that actually make it in the door, for lack of better words, are going to generate a remittance advice. Sometimes people refer to this as the notice. Other people just simply call it the RA or the remit. There are two different formats for the RA, the electronic remittance advice, and the standard paper remittance. And with few exceptions, most of our providers receive the electronic remittance advice or the ERA. Now that RA provides very important information to the provider. For those claims that are actually adjudicated, those that aren't rejected, you're going to find information on the remittance advice about adjustments, denials, and those other items listed here on the bottom right side of this slide, including refunds and even offsets. When looking at a remit, you will find various reason and remark codes. Now, these are typically in an alphanumeric format, and when claims pay differently than they were billed, a claim adjustment reason code is going to appear on that remittance advice. And sometimes a remittance advice remark code also appears. Now, these do expand on details that are described by that reason code and do so in order to provide more details about the adjustment to that particular claim or claim line. Now, another type of code on the RA is a group code, and group codes assign financial liability. That is for any unpaid balance on the particular claim. A CO group code stands for contractual obligation, and what this means is that the provider is liable and can't bill the patient. A PR group code, on the other hand, is patient responsible. Now, we hear a lot of comments about those reason and remark codes. Our customer service agents often hear from providers calling in that those reason and remark codes are too cryptic or that they contain outdated acronyms. While we'd really like to help, it is another CMS contractor, not WPS, who maintains those codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website, and it is on their website where you can find contact information should you wish to suggest a change to those sometimes cryptic code lists, including those explanations. Here is a slide that I've included in today's presentation that compares a rejected claim to a denied claim. And these are really very, very different. I think that people often use these interchangeably when we really shouldn't, because they mean different things. I find myself sometimes calling a rejection a denial and vice versa, and I have to correct myself because they are really different. If you look on the left side of this slide, you'll see information for rejected claims. Rejected claims are called by CMS unprocessable. We can't process them. They're actually returned on what we call the front end before a claim can be adjudicated. The reason they're returned or they're unprocessable and rejected is because something is illogical, something's missing or incorrect. CMS publishes claim processing or claim Claim form instructions, there I go. And it says in item number 1 on the claim, you need to put this. In item number 2, you need this. Number 3, you need this. Now there are some items on a claim form or the electronic equivalent that are situational. You don't always need to populate or put something in that particular segment of the claim or loop of the claim or item on the paper claim. But most of the items are going to require some information, and if that's missing or incorrect or illogical, in other words, maybe entered in a format that's not approved, then it's going to reject. For rejected claims, because they're never processed, really processed or adjudicated, there are no appeal rights. You need to fix it and resubmit it. When you look at a remittance advice, if you see an MA130 and C016 code on that remittance advice, it means that claim was rejected. The patient is not liable. A denied claim, on the other hand, is actually adjudicated by the Medicare Administrative Contractor. Today we're talking about Jurisdiction 5 and Jurisdiction 8 claims, Part B claims that is. That's our MAC jurisdiction, Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan, all Part B claims. We deny claims for various reasons. I've placed a few of them here on this slide. Maybe there is a law that says we can't pay for an item or service. That's a statutory requirement. Sometimes we deny services based on medical necessity. And medical necessity for Medicare purposes does include any frequency guidelines or utilization parameters. Anything that has a frequency guideline would be a form of medical necessity. Other reasons we may deny a claim is eligibility. Maybe the beneficiary wasn't eligible for Medicare benefits on the date of service. And similarly, it could be that the provider was not eligible on the date of service. All of that information for the provider would be contained in the provider's provider enrollment file. Now, for a denied claim, most often, with few exceptions, you will see an MA01 code on the remittance advice, and that provides appeal rights. As I mentioned earlier, patient liability for denied services is determined. Now, during the next few slides, I'm going to discuss whether you need to correct or fix and resubmit or appeal a claim. After reviewing the remittance advice, you're going to need to choose an action to take. So for an unprocessable or rejected claim, you're going to need to fix it and resubmit your claim to Medicare. If the claim or claim line denied, there may be multiple actions that you can choose from. You may be able to simply resubmit the service. You might be able to use the clerical error reopening process to fix a clerical error. And CMS defines a clerical error as a human or mechanical error on the part of the provider or the contractor. Another action to consider is an appeal. The remittance advice is going to provide those appeal rights with few exceptions. I'll discuss appeals in just a couple of minutes. Registered users of our SecureNet Access Portal, or what we call SNAP, that's our self-service secure portal, can render or request a clerical error reopening or request an appeal. Now, these are self-service tools that SNAP, those functionalities of SNAP, that really do offer the most efficiencies. We do have a portal user manual that provides illustrations and step-by-step instructions on how to use the various functionalities of the portal. And I'm going to show you where you can find that information. I'm opening it on my other monitor. I'll pull it over, let you take a look. Bear with me while I get it set up here. I have a lot of windows open currently. All right. This is the homepage of the WPS website. The website address is listed in your resources, so you'll be able to find it later. But this is our homepage. I'm going to scroll down here a little bit so you can take a look at it. I mentioned to you the portal user manual. There's more than one way to find the portal user manual, but maybe one of the easiest ways is to go near the top of our homepage under the large blue box where there is the green login, this is the login that registered users of SNAP can use to get into that secure portion of our website. Right under the login button is a link to our portal user manual. That is the manual with step-by-step instructions and illustrations. And I always say, who doesn't like pictures, right? This is the portal user manual that explains all of the functionalities of SNAP, including the clerical error reopening and ways to request an appeal. Now, if you move to the bottom of our our homepage or any page on our website, in the middle column in green is educational opportunities, the heading. Right under the educational opportunities is the portal user manual link, so you can get there easily. And just as an aside, if any of you are interested in following us on Facebook, right here is a place where you can hover over the Facebook icon, take you out to Facebook, and you can look for WPS Government Health Provider Information or provider webpage if you'd like to follow us on Facebook. Bailey will place something into the chat a little bit later on in this presentation that will remind you of how you can follow us on Facebook. A lot of providers don't know about that, so I think it bears mentioning. All right, those are the potential actions to choose. I did promise you a little bit of information about appeals. If I wanted to tell you all about appeals, I'd need at least an hour to do so. We do have some terrific resources available for you. I'll talk about those in a minute. But there are 5 levels of appeal. For claim denials, most often you can request an appeal, and the purpose of the appeals process is to ensure the correct adjudication of claims. Now, physicians, suppliers, and beneficiaries have the right to appeal claim determinations that are made by the MAC. That's that initial claim determination. The beneficiary or the representative may request an appeal on any service processed for them. Providers and suppliers may appeal services for which they accepted assignment. For unassigned claims, though, providers and suppliers can act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement to do that. Additionally, for non-assigned claims, a provider or supplier can request a redetermination, that's the first level of appeal, on an unassigned claim if Medicare denied the service as not reasonable and necessary, or in those situations where the provider may have billed in excess of the limiting charge. And of course, in that case, the provider would need to refund any fees collected from the beneficiary in excess of that limiting charge. Now, the first level of appeal is the redetermination. The redetermination level of appeal is the only level of appeal that's rendered by the Medicare Administrative Contractor, or by WPS. There are timeframes that apply to each level when you're submitting a request for an appeal. Additionally, there is a minimum amount in controversy that applies to levels 3 and level 5. The administrative law judge hearing is level 3 appeal, and federal court review or federal judicial court is level 5. Now, those are dollar thresholds that apply. You have to meet that dollar threshold in order to request that particular level of appeal. And you can combine similarly denied services on more than one claim in order to reach that amount in controversy, or what we call the AIC. Here are a couple of resources that I've included for you. One is a resource on our website called How to Appeal a Claim Determination. That includes addresses if you want to mail your request, but remember, using SNAP, that self-service secure portion of our website is the quickest way for you to request an appeal. The second bullet here on this slide is the CMS fee-for-service appeals process flowchart. This is one of my favorite resources, so I like to share it when I'm talking about appeals. And the reason I like to share this, it's opening up, and I'm going to pull it over here for you in just a moment. Make it a little bigger than what you see in the as the decorative form on your slide presentation. But here is the excuse me, the actual appeals flow chart that appears on CMS's website. It's for Original Medicare, both Parts A and B. Today I'm talking about Part B, so I'm following the left side of this flow chart, the standard process for both Parts A and B, but we're talking about Part B. Here's that initial determination that's done by the MAC. That's when your claim is initially processed by the MAC. It shows you have 120 days to file the first level of appeal, which is the redetermination done by the MAC. The MAC has 60 days to render their decision and send you notice. If you don't agree with the outcome of first level of appeal, you have 180 days to file the second level of appeal, which is the reconsideration rendered by the qualified independent contractor. We sometimes call that the QUIC. They have 60 days to render their decision and send you notice, and so on and so forth. You can see the time limit to file your request and the time limit that the contractor has to render their decision and send you notice. I mentioned to you those amounts in controversy just a couple of minutes ago for level 3 and level 5. And here they are right here on this flow chart. The amount in controversy for a level 3 appeal, Office of Medicare Hearings and Appeals, known as the ALJ hearing, is greater than or equal to $190. The amount in controversy for the 5th level is greater than or equal to $1,900. And you'll notice if you're looking at this flow chart that there's no time limit that federal district court has to render their decision. There are a lot of things that come into play here. One of them, of course, would be the court's calendar. Now, those amounts in controversy that I mentioned can change from year to year, and most often they do. I want to make sure that you're aware that at the very bottom of this CMS flowchart, they do tell you that the chart reflects the amounts for a particular calendar year. Of course, we're in 2025 right now, so it's showing 2025. Keep this in mind. When January comes along, it might take CMS a little bit of time to get this flowchart updated. So make certain that you're referring to the calendar year on the flowchart, because these amounts in controversy may change on January 1. Okay. All right, let's move on now into the next portion of today's webinar that really focuses on the data. I used a tool that we call the Claims Data Dashboard to pull the data that I plan to share with you today. And that data dashboard is an interactive tool. It was designed by those data analysts in our Insight department. That's the name of the unit at WPS that's responsible for mining the data, looking at data trends, among other tasks and responsibilities. There are different ways to view the data. People like Bailey and me and people in customer service can come out and look at this data to determine if rejections or denials are increasing or decreasing. We can, in an instant, view rejections versus denials. We can drill down by state or even county. The dashboard shows these by reasons, by codes, and even by specialty. We can use the dashboard to view trending, as I mentioned, and this alerts us to those spikes or those increases that really require attention if we're doing what CMS tells us we have to do in their internet-only instructions. I want to talk a little bit about data slicers. And that was kind of a new term to me, but really it's no more than a drop-down menu in that tool that we use, where we can choose various bits of information or filters, if you wish, to look at the data. So today I'm talking about MAC jurisdictions 5 and 8, Iowa, Kansas, Missouri, Nebraska, Indiana, Michigan, Part B only. Specialty 47, which is the specialty code for independent diagnostic testing facilities. The submission dates for the claims that I analyze data for are April 1 of 2025 through June 30th. That's a 3-month time frame. The data was last refreshed shortly thereafter in July. Our data analysts every month will add a new month of data and remove, the last month of data, 3 months at a time. I do want to show you quickly, if you can bear with me just for a moment while I open it up. I'm opening up that tool just so that you could take a look at it. Getting it ready. All right, it's coming up. Thanks for standing by. We can look at these rejections and denials in a number of ways. What I want to show you just real quick, so you get an idea of what it is I use to mine this data. I call it mining the data. This is the data dashboard. So we can use these data slicers here to choose what we want to look at. So I chose all jurisdictions, jurisdiction 5 and jurisdiction 8, only part B. I looked at both rejected and denied claims. I'm going to move this, take this code away here, take Michigan away because I looked at all the states. And I looked at denied claims. You can see here, though, that this dashboard has changed since I looked at data. I told you that I looked at data April through June. Right now, the latest and greatest information is June through August. Last refresh just recently on September 11th. So very quickly, we can change just at a click of the button and look at different data slicers to look at data. You'll notice I just looked at denials. Now I'm looking at unprocessables. If I want to choose a particular state, I can do so. Let's see, I'm going to choose one of our states. Let's see, Michigan. We have some Part A states that are other than Iowa, Kansas, Nebraska, Missouri, Indiana, Michigan. That's why you see so many states listed. So we can do this really quickly. We can search by a particular CPT code, just like that, just at the click of a button, and it will tell us the top reasons for denial, and it will tell us how many claim lines. So you can see this is some really great information, and we do need to take a look at that based on CMS's instruction, and then provide education like I'm doing today to alert you to the top rejections and denials for your particular specialty. I'm doing all of the specialties. So I'm at 47, I started at 1. So here then are the most common reasons by Part B claims during that time period I talked about rejected. Remember that rejections are different than denials. You need to fix it and resubmit it. The number one reason why Specialty 47 claims denied, and for those of you that are wondering what a specialty code is, I've mentioned it a couple of times, it's a 2-digit code that's assigned to providers when they enroll. During enrollment, providers will self-designate a specialty. Most providers, some don't self-designate. While a provider can designate a secondary specialty in some cases, it is only that primary specialty that's used in the claims processing system when a claim is initially processed. Now, there's some situations where a provider can request an appeal and stipulate their secondary specialty in order for Medicare to make payment. But we looked at specialty, or I looked at Specialty 47 claims, which is the 2-digit codes assigned for independent diagnostic testing facility. The number one reason why Specialty 47 claims rejected was that the clinic number was missing from the claim or not entered. That's a required element. 305 claim lines didn't rejected. I caught myself there during that time period. The number 2 reason for rejection, 137 claim lines, was that the claims must be submitted to the Railroad Retirement Board. Beneficiaries that are eligible for Medicare Part B under Medicare that are retirees of the railroad have their claims submitted or processed by the Railroad Retirement Board, which is Palmetto GBA. You need to submit their claims to them, not to WPS. How do you know if a beneficiary is eligible for Medicare through Railroad Retirement Board or has railroad retirement benefits? You need to check eligibility. Check that eligibility. You can also check their card when they present at the office. Right at the bottom of their Medicare card, it will state Railroad Retirement Board on the bottom if it is a Medicare Railroad beneficiary. Third reason for rejections, incomplete, invalid plan information for other insurance. 97 claim lines rejected. What this means is that you told us on that claim that another plan or the patient has another insurance, but you didn't complete the plan information, or you placed invalid plan information on that claim. Next, this facility is not certified for digital mammography. There are guidelines for certification of facilities that can, under Medicare, bill for digital mammography services. If you're not certified to do so, the services aren't allowable by Medicare. In fact, the claim will be unprocessable if the facility is not certified. There's a certification number you need to enter on your claim. If it's illogical, missing, or there and doesn't make sense, or that facility is not certified, it's going to reject. 92 claim lines. Rendering physician number invalid or missing from a claim, there was 43 rejections, kind of self-explanatory. And then we have CLIA number, invalid or missing. Under the Clinical Laboratory Improvements Act, those facilities who render certain classifications or types of laboratory procedures must fill out forms and certify their facility in order to bill them. If you bill for one of those services on your claim and you don't include the CLIA certification number on the claim, or if it's invalid or missing, your claim will reject. And I'll give you some resources later so you have more information to come back to these. The next reason for rejection kind of goes along with that second most common rejection for your specialty. This claim has been forwarded to Palmetto, which is the Railroad Retirement Board. So 27 claim lines, information required to make payment missing, that you would need to look for other information relative to the claim or the claim line to determine what it was that was missing. Invalid or missing modifier is another one of those top or most common reasons for rejections for specialty 46 claims, or 47, I apologize. If you're looking at the WPS website and you want to find information about modifiers, there's a number of ways you can go about it. You can navigate from the topic center by going to claims and then looking at modifiers right here. Or you can simply go to the search box, as do I. I'm a navigator, not a searcher, and type in modifiers. And there they are. This is the results for my search. I searched modifier, singular. And then here you can show or click on the modifier webpage, and this will bring you to a listing of modifier fact sheets. I like these fact sheets. I'm going to open one and show you an example. I like these because every single modifier fact sheet on our website will have for you the definition of the modifier. We include appropriate uses, we include inappropriate uses, and sometimes we include even more information. For this one, we included some statements that are false, and we also included the procedure codes to which you can append this modifier. Now, if I submitted a claim, if I'm a provider and I submit a claim and I add a modifier 25 to a CPT code or HCPCS code other than these, that claim is unprocessable because that's CPT code and that modifier don't go together. It's illogical, so the claim will reject. What do you need to do? You need to fix it and resubmit it. Okay, so that's just an example of modifiers. And then here is missing, incomplete, invalid ordering primary identifier. Medicare requires that an ordering provider be placed on the claim or identified on the claim for certain services that are billed to Medicare. If it's missing or incomplete or invalid, your claim is going to reject. You're going to need to fix it, resubmit it. CMS maintains a list of ordering and referring providers on their website for all providers who are eligible to order and refer Medicare services. That particular list includes the NPI, or the National Provider Identifier, of each one of those ordering or referring providers so that you can make certain you're entering that number correctly. Now, I've included that listing later in the resource section of today's presentation. So those are the reasons, most common reasons for rejections. Which codes were those that were most commonly rejected? Here they are. 71046, this is the chest x-ray 2 views. There are physician supervision and technician requirements in one of our articles that is published out on our website. It's A54963. The number one reasons, the top 3 reasons that that particular code is rejecting is that the clinic number is missing or not entered, that claim should be sent to the United Mine Workers of America for processing, kind of like that Railroad Retirement Board, those that are retired miners and have their Part B claims processed or benefits processed by the United Mine Workers of America, and it needs to go there instead of to WPS. And the other common reason is that there's incomplete or invalid plan information for the other insurance. The next two most commonly rejected codes for your specialty are 77063, which is breast tomosynthesis, and 067, that's screening bilateral screening mammography. And here are the reasons. The facility is not certified to do the service, the claim must be submitted to the railroad board, and incomplete, invalid plan information for other insurance. Let's take a look at more codes. 74018 is an X-ray of the abdomen, one view. Here are the most common reasons why this is being rejected. Nothing new here. All of these we've already talked about. 82565 is a creatinine lab. The only reason we rejected that particular service for your specialty claims is that the CLIA number was missing or invalid. 76562 is a 3-view knee x-ray. Here are the top 2 reasons we rejected it. Nothing new here, those that we've already talked about. And then A9585, which is an injection. It's a contrast agent for MRI scans. These are the reasons why we rejected it. Nothing new here as well. I talked about rejections. Now I'm going to switch gears and talk about denials. Remember, at a click of the button in that dashboard, I can look at rejections versus denials. Here are the top or the most common denial reasons for specialty 47 IDTF claims. The physician or provider is not eligible to receive payment. 980 claim lines denied in 3 months. The provider number is not valid for these Medicare services. That's something you'd probably want to check your provider enrollment files or make certain that you entered that provider number correctly on the claim. The next one is one of those kind of cryptic reason codes, collection of fee-for-service during periods of managed care. When you see that on a remittance advice, it means your patient or that patient has elected to receive Medicare Part C benefits. It should go to the Medicare Advantage plan, the managed care plan, which is not WPS. Eligibility would be your where you need to look for help there. The referring provider is not eligible to refer the service. 258. Remember, CMS maintains that list of providers who are eligible to order and refer services to Medicare, so you'd want to check that list. Here's one that keeps coming up over and over. Duplicate charge paid on such and such a date for claim such and such. Okay, when I say such and such, I mean a number, claim internal control number, ICN we call them. 235 duplicates. Look at the 4th bullet here. This is another form of duplicate denials. This is a duplicate charge. Duplicate denials have been and continue to be problematic, not just for WPS, but for other Medicare contractors as well. I've worked for a number of years in Medicare, and this has long been one of those most common reasons that we deny claims. Providers need to make a good faith effort to check the status of their claim before just automatically resubmitting a new claim. If you resubmit a new claim and there's nothing changed on it, it's going to deny as a duplicate. Maybe it's a service that's another claim that's currently in the system. Maybe it's one we processed before on another date. There's different types of duplicate denials. Now, there are some modifiers you can add to services, 76, 77 modifiers, those that indicate to Medicare or tell the claims processing system by use of that modifier, this is a repeat service on the same day by another provider, or this is a repeat service on the same day by the same provider. Sometimes there's a modifier you can append that will avoid your claim from being denied as a duplicate. We do have in a resource on our website some help that you can find for duplicate claims. Another most common reason for denial is that a skilled nursing facility episode of care notice has been filed for this patient. What that means is the claim should be paid for, or the services are the responsibility of the skilled nursing facility, and you shouldn't bill that service to Part B. It's part of SNF consolidated billing. We do have consolidated billing education available both in videos on our YouTube channel as well as on the CMS website and on our website. And all of those are included in the list of resources available at the end of your presentation materials. Not covered when performed, ordered, or referred by this provider. This is an eligibility type of denial. You need to make certain that that particular provider is certified or able to order or refer that particular item or service. We talked about duplicate charges, missing, incomplete, invalid ordering provider name on the claim, 154 denials in that 3-month period. You need to include that information on your claim, and it needs to be valid. Claim must be sent to the employer group health plan first. This is a Medicare secondary payer denial. This would be something where you'd want to check the patient's eligibility to see who's responsible for payment of that claim. On each and every claim, you need to include whether there is another insurance that's primary to Medicare, and if you tell us yes or no. If yes, you need to enter additional information onto that claim that identifies that employer group health plan so we can have them process claims and primarily, and then Medicare would be secondary. Now here are those codes or the top denials for specialty 47 claims by code. 93971 is #1 on the list. This is a duplex scan in extremity veins, arm or leg. Physician or supplier not eligible to receive payment. Duplicate and a SNF episode of care has been filed for this patient, which means that the skilled nursing facility is responsible for the payment of that particular procedure, that duplex scan. Q9967 is contrast, low osmolar contrast. Here are the reasons we denied it. Nothing new there. We've talked about these already. G0248 is demonstration at initial use of home INR monitoring. This service was billed to us as a telehealth service, and it's not on the list of covered telehealth services, so it was denied. And Medicare will not pay for this particular service. It was the other reason that that was denied. 76705 is an echo exam of the abdomen. Something new popping up here is bundling. If you look at the third bullet under 76705, the payment for that service is included in other services on the same day. So Medicare won't separately bill for 76705 and denied the service. What you would want to look at here is the National Correct Coding Initiative edits. There are procedure-to-procedure edits when more than one service is rendered by the same provider for the same patient. On the same day, you need to look at those edits to determine if a modifier can be appended to the column 2 code. There's always a pair of codes. If a modifier can be appended to the column 2 code to unbundle payment. And just because there's an indicator that says, yes, you can add a modifier, doesn't mean, yes, add it. It means look in the medical records to see if the documentation in the records justifies appending that modifier to that procedure code. Just don't automatically append it. You need to make sure that there's documentation in the records to do so. A9573 is a code that refers to an injection. It's used for billing and reimbursement of the MRI contrast agent. Here are the reasons it is being denied. Take a look at the third bullet there, not medically necessary. That means that there's policy. Okay, policy equals edits. Policy defines medical necessity. So for this, or any service that is denied due to medical necessity, you need to be looking to either a national coverage determination, one that applies to everyone everywhere, or a local coverage determination that would apply to claims processed by a particular MAC that authored that local coverage determination. So in that case, I'd go looking for the policy to see why, based on the information on that claim, that service was not medically necessary. Now, if you're using SNAP, our Secure Net Access Portal, and you're looking at your line on a claim and you're seeing that this code denied, you can click on the More Info button, and it will likely provide for you a link to the very same policy that stood for the reason why this was denied. So just kind of a plug out there for our self-service tool, that is SNAP. If you're using that and looking up denials, if something denied based on a policy, you're likely going to be able to click a button and look at the policy. A9952 is a code for F18 FDG. That's just the abbreviation for something very long. Radiopharmaceutical fluorodeoxyglucose. Glucose. Hard one for me to spit out, folks. It's F18 FDG. It's a diagnostic agency that's used for PET scans to evaluate metabolic activity. There are the reasons we denied those claims. In such a case where a current invoice or radiopharmaceutical billing form is needed, you would have to indicate on your claim that you have documentation available upon request so that we could request that information from you. If you don't include it, your claim is going to deny. Missing, incomplete, invalid ordering provider name, and then Medicare will not pay for this service for this condition. That, folks, is medical necessity. So you should be policy that has this code in it. And remember, our codes don't appear in the policies themselves. Codes will appear in the billing and coding guidelines that are associated with a particular policy. We have a lot of education, a lot of videos out in our on our YouTube channel that talk about policies if you're interested in that. 71046 is chest x-ray to view. You can see the reasons here for denials, provider number not valid, and collection of fee for service. And then the 93926, which is related to non-invasive peripheral arterial vascular studies. There are covered diagnosis codes in the article, and the article number is A57593. So if you're getting denials for this based on medical necessity, if you're getting a remit that says Medicare will not pay for this service for this condition, look at our article. That's the companion article to our local coverage determinations or article. That is A57593. I can show you real quick how to look for that. Bear with me, I'm pulling it open on my other screen. Here we go. Policies are not housed in their entirety on the WPS website. They would be on CMS's website. And what I would do is I just search A57593. That's the article number on CMS's website. And it will open, and here it is, A57593. I open the article on CMS's website. I want to check contractor information to make sure it's WPS's article, and yes, it is. You can see that this article is superseded, so you need to go to the public version section to see the latest and greatest, and then open it up. And this particular article will list CPT codes and then the ICD-10 codes that WPS considers as medical necessity for that particular item or service. Okay, so that is how you find an article and the coding and billing in it. All right, I wanted to talk with you just a little bit about a trending example. I looked at the dashboard and looked at trending for this reason. Claim must be sent first to the employer group health plan. I saw that the current 3-month denials is 152, but prior 3 months was only 50. So that's a difference of 102 and represents a 204% increase over that 3-month period, from one 3-month period to the other one that I compared it to, or to the prior 3 months. So that means we're spiking a little bit for this particular reason. So that means I might want to consider or find out, do we already have education that addresses this? How do I alert the provider community to this? Do we send out a news item? Do I schedule a webinar on it so that we can fix this or avoid this particular denial reason. That's what CMS wants us to do with this data. So here then in the next few slides, and I'm going to go through these rather quickly because I've really talked about a lot of this already. This was the information at the beginning of the presentation too that I said I would be going over rather quickly. So I've included in your presentation materials reminders of what I talked about here. For modifier issues, and I'm going to pause for just one moment. Thanks, folks, for hanging in there with me. These are the, scroll too far here, the modifier issues. I talked about that. I showed you already. Going too quickly here. I showed you already where you could find the modifier fact sheets on our website. Make certain that your modifier matches the procedure code. Sometimes those modifiers that are created are only valid on a particular date of service. Sometimes they're terminated. So you need to make certain that the modifier is valid for the date of service that you're billing on your claim. Eligibility fixes. This includes both patient eligibility and then also provider eligibility. But for patient eligibility, there are various tools that are included in your resources to help you know how to check eligibility. Make certain your patient name and your MBI match exactly. If there's a middle initial for your patient on that their Medicare card, you need to make certain it matches on your claim form. Include that middle initial. Submit services to the correct payer. A couple that we talked about are the Railroad Retirement Board, Medicare Advantage. Some claims we're rejecting or denying because patient had Medicare Advantage. Claim shouldn't come to WPS. And another one for one of those codes that we talked about was the United Mine Workers of America. That goes to their benefit plan or health and benefit plan. Provider number fixes similar to beneficiary numbers. Make certain that they're being keyed correctly, entered in the right place on the claim form. Make certain your provider enrollment records are valid, and to contact provider enrollment, you would call customer service and they would connect you with a provider enrollment specialist. Sometimes a provider is associated with a clinic. You need to make certain that the provider is associated in our provider eligibility files, with that particular provider that's billing or clinic. And make sure that you're entering ordering provider information on the claim form and identifying those providers. Duplicate denials I've talked about already. We have a denials article or resource on our website that has various categories, and duplicate denials is one category. It talks about ways to avoid duplicate denials. Make sure you're billing appropriately, you're using appropriate modifiers, and don't automatically resubmit your claim prior to establishing the status of that claim. If you're using a billing service that automatically or on a cycle submits claims every 30 days, tell them to stop doing that. It is considered abusive. You need to establish the status of the claim first before auto resubmitting. Here's some resources for you to avoid MSP denials. I talked about some of these a little bit earlier. We have some great YouTube videos available. I've included or embedded links for those. And then just a fact sheet and other information that CMS makes available on their website. Here are more resources and tools. These are those claim processing guidelines that I talked about. It says if you need to complete item number 1 on a claim form. Is it required or is it situational? Well, how do you know that? What about those providers that are billing electronically? Where does it go on that electronic claim form? If you look to the WPS website, and I'm opening this up because I want to show you something that I know providers don't always know about, but it is helpful. This is not, this is our intranet page. Here is our provider homepage. If you go to quick links on our homepage and choose EDI for electronic data interchange, you'll notice that I'm on another website. I'm not on the WPS website anymore, but WPShealth.com website. This is our EDI webpage. We have Medicare business, we have TRICARE business, and of course we have our commercial insurance. But you and we are talking about Part B Medicare today. So we're going to choose Medicare EDI. Way at the beginning of my presentation, I talked about those companion guides that tell you about the elements of the claim that are required, or the data elements, those 276, 277 reports and the companion guides. This is where you find them. But what I want to show you now is the crosswalk. I'm crosswalking a 1500 claim form to the current 837-5010 electronic claim form. This is what we call the crosswalk. And if you scroll through this crosswalk, at the top of every page, you'll see the column header. The first is item number. That's the item number on a paper claim. Then is the narrative. What is it? Then there is information as it relates to the electronic claim form, the data element, or the data element description, the loop, and so on and so forth. Then requirements for the version 5010, which is the current version of the electronic claim form, and the status code. So this says if it goes in item 1 on a paper claim form, the type of health insurance, where does that go on the electronic claim? This tells you right here. The status code column is very important. You'll see a number of R's here, but down here for item number 4, or the electronic equivalent, it's situational, S. Right here, it tells you R is a data element that's required in order to process a claim, and S is situational, must be completed if other conditions exist. This is what I was talking about earlier with rejected claims. If something is required but it's missing, it's rejected. You need to fix it, resubmit it, and this crosswalk will help you know what needs to go where on that electronic claim. Okay, so good information. I've included that in your resources. In the very next slide here. Oh, I lied. It's not on the very next slide, but it's there. It's that crosswalk. And here is the claim form instructions, what you need to put in the claim and where, electronic and paper. This is a bit of information about the IVR, where you can find claim status. We have an IVR operating guide that tells you how to use this self-service tool. You use your voice or telephone keypad to get claim status and details. Similarly, this talks about our SecureNet Access portal. Here's another link to that portal user manual. SNAP is different because you can also check eligibility, including and in addition to the claim status and claim details and actions. Remember that more info button. We have a couple of resources on our website. One is for rejected claims, and that's here on this slide. I've linked to it. And one is for denied claims. In both of these resources, and I'm just going to click back and forth here, we list by reason and remark codes reasons for rejections and denials. So if you get your remit, you see a reason code or remark code on there for a rejected or denied claim, go to these articles, look for that reason or remark code, and it tells you how to fix it. In addition to the things we've talked about today, of course. Here are more WPS resources. I talked about requesting a clerical error reopening. If you open this particular resource, and it opened on my other monitor, opens our website. I'm going to say Part B, Jurisdiction 8. This tells you the definition of a clerical error, what you can process or what we can process as a clerical error, and what cannot be processed as a clerical error, and so on and so forth. Time limit is 1 year. So some great information about that clerical error process, just one of those actions you can choose to fix claim. Modifiers webpage, timely filing of Medicare claims is here as well. Timely filing provides some great information about timely filing of claims. You have 1 year from the date of service. It also tells you why we can't reopen some claims, and I'm going to give you an example. Let's say an insurance company is primary over Medicare. They make payment and you think, oh, they paid it, I don't have to submit a claim to Medicare. So you don't. 3 years later, that insurance company comes back to you and says, guess what? We weren't primary. Medicare's primary. We want our money back. So you have to pay the money back. CMS says that that is not a valid reason we can waive timely filing requirements. Unfortunately, we can't reopen a claim and pay in that situation. This article talks about that. Here are independent diagnostic testing facility enrollment requirements, certification requirements and such. I know some of you, when you registered for today, asked or said that one question you have is a question about certification. Today's webinar is about common rejections and denials. If you want information about certification and enrollment requirements, here is a resource for you. More resources, clinical lab and reference laboratory services coding guidelines. This talks about CLIA. I know CLIA was a reason why claims were being rejected or denied that we talked about earlier. Live events, encore presentations. This is those recordings that are available 60 to 90 days. And then we place those same recordings out in our YouTube channel. We actually do it simultaneously, so they're likely already there at the same time as that. As the Encore presentation. Here's the EDI webpage that I linked to. Here, folks, is where that link to the crosswalk is. The one that I just showed you. If it goes here on a paper claim, where does it go on the electronic claim? Here are more resources available. Eligibility. This is a eligibility. This will help you determine or check Medicare eligibility for your beneficiary. This is an interactive map that will tell you who the contractors are in particular states, go by state. Here are those files that include all of the eligible ordering and referring providers, also includes their national provider identifier. Here is another link to the CLIA webpage. More CMS resources. For bundling, you can check the physician fee service relative value files. If there's a B status code column, that means that CPT code or HCPCS code is always bundled into other services on the same day. Or also for bundling, you can check the National Correct Coding Initiative edits. Here's some information about SNF consolidated billing, because that was one of the reasons for denial. It says that a SNF notice has been filed for this patient. That means you need to consider SNF consolidated billing, and the nursing home is responsible for payment. Here is links to those National Correct Coding Initiative articles, those procedure to procedure edits, which bundle column 2 codes into column 1 codes. Tells you if you can append that modifier to unbundle services. This brings us, I'm talking very fast, I know, because we are going just a little bit over, and I apologize for that. I know that you're all busy, so I am going to wrap things up and tell you that I will respond to any questions that have been placed into the chat, and I'll tell you in just a minute how you can submit questions for a period of 7 days following this event. It is right here that I tell you you can send an email to us. If you think of a question between now and 7 days from now, put today's topic, IDTF, rejections and denials, into the subject line, and they will forward that email that comes into the education mailbox to me, and I will either send you an email with an answer directly to you, or I will compile a list of questions and answers and send it out to everyone who's participating today. Remember, I can't answer any claim-specific questions. They need to go to customer service. If you are seeking CEUs, please listen closely. Following today's presentation, and probably already because I'm running over a little bit, you will receive an automated email from WebEx, not from WPS. Within the body of that email will be your certificate of achievement. Look for information that reads similar to what you see over here in this red box at the bottom of the page. It will have contact hours, today's date, and the name of this presentation. Take that email and forward it to the accrediting body of your choice and ask them to award you CEUs. Okay. Now, if you joined only by phone today, in other words, you're not watching this slideshow, you're just listening, you'll get another email from WebEx. What you need to do is submit an email to WPS telling us that you joined by phone only. Give us your phone number, today's date, the name of this presentation, and we will manually create and send you a certificate of achievement. The email address is on the next slide, and Bailey's placed it into the chat. I lied, it's on the very next slide. It is wps.gha.education@wpsic.com. Tell us you're looking for CEUs, you listened by phone only, and give us your phone number, the name of today's presentation, and the date. The next thing I'm going to talk about is that ever important survey. And if you've ever been to one of our presentations before, you will know that we ask you to complete a brief survey following our events. We're committed to making changes based on your feedback. CMS and WPS looks at every single one of those surveys. If you can't give me all 5 todays in that survey, you need to tell me why so I could do better the next time. Include your wish list. What is it you want to hear about in the future? We have made changes based on survey comments. We've added chapters to our YouTube videos so you can move through a recording of our video. You don't have to listen to the whole thing. If you want to listen only to rejections in today's presentation, the recording that I plan to make, you'll be able to do that. You can go right to rejections by using chapters. You can go right to denials by using chapters. We've also added training indicators to the webinar descriptions so that you can determine whether that particular education is really geared to what you do, what your responsibilities and tasks are. One last thing, we scheduled another Medicare Education Expo event. It is on October 16th of this year. Bailey has placed some information into the chat about that event. We did that because we held our first MEE, or Medicare Education Expo, in July, and we got such great feedback and people saying, do this again, that we're doing it again. So that just shows you how important that survey is. And here's information about the survey. Take time to complete it now while everything's fresh in your mind. Bailey has added a survey link to the chat, and we're giving you one last, and it's really not your last chance because you could use that survey link anytime to provide feedback on this. But when you close out of the webinar today, when you leave the webinar today, you're going to get a pop-up box that'll look like what you see there with the yellow triangle and the blue continue button at the bottom saying you're going to CMS's survey site. Please take our survey. It is so very, very important, and we really, really appreciate your feedback. Get a lot of great feedback there, and we appreciate it. With that, I want to thank you again. We've gone over just a little bit, but we do appreciate your time. We know how busy you are. Your feedback's important. Make certain you're filling out that survey. We look forward to those comments, and we hope to have you join us for future events. You may now disconnect. Thank you, everyone. Have a wonderful day.